we have started with the pathology of the pelvic organs. So right now, so that will be discussed, I think, in the later lectures, right? So I'll start with the malignant disease of the cervix. So the objective of this lecture is that you will be able to identify the pathophysiology and risk factors for CS cervix, and to identify the clinical features, the workup of the CS cervix and staging of CS cervix, and to understand the management plan of various stages of cervical cancer. So, cervical cancer is the second most common cancer affecting the women worldwide. The incidence of cervical cancer is low in well-developed countries, but due to proper cervical screening, around 5,000 deaths are prevented every year in UK. They have got the system that every woman after the age of 25 years, they have to have the cervical screening with the name of pap test, that is pap smear. So they do call everyone, then their health system is that NHS do call them for the pap test, for the cervical screening test, which is called pap smear or pap test, every 3 years in the beginning, depending upon the results of the pap test. But the problem is that in our country, our underdeveloped countries, this is not so common. Even the educated people may not be knowing about the importance of pap test. So it is very important to have a screening test for cervical cancer, which is called pap test. So because of this cervical screening, in UK, the deaths have been prevented every year and the incidence is low. But in underdeveloped countries, the mortality is 10 times higher as compared to developed countries. And every year, 80% of new cases come in our OPD or worldwide, in our country. So it is the 19th most common cancer in UK and constitute 2% of all cancers in women. The lifetime risk of developing cervical cancer in UK is 1 per 134 women. Age-specific incidence rate varies because the initial, we can say the pre-malignant condition, the first peak occurs in the younger women between the age of 30 to 34 years, and second peak occur in older ages, that is 80 to 84 years. So that means in the early peak ages, or you can say the younger age group, the most common pre-malignant condition, that is CN1, 2, and 3, are picked up by going for the biopsy with the pap test. And second peak occurs when there is established CS cervix. So if pre-malignant condition is treated earlier, the chances of having cervical cancer is decreased. The survival rate is 84% for first year, falling to 67%, surviving 5 years to 63% for 10 years or more. The risk factors, now talking about the risk factors, what are the risk factors which lead to cervical cancer? So one of the most important risk factor which has been talked about a lot in gynae and obs is the persistent infection with high risk human papillomavirus. Now the vaccine is also available, but still in our setup in underdeveloped countries, it is still not that common, but in developed countries, the vaccine, HPV vaccine has been started to the younger girls in the school. And so that may also may help to prevent the cervical cancer in the later ages. So HPV infection, HPV has got many strains. So the most common strains which are associated with CS cervix are 16, 18, 31, and 33. Other factors, early age, adverse intercourse, and multiple sex partner. Other sexually transmitted infections such as HPV and chlamydia infections together increases the risk by 80%. And it is doubled in women with both herpes and human papilloma infections. Immunocompromised states like women with HIV, AIDS, or on immunosuppressants are at high risk of developing cervical cancer. It has been seen that Black women with HPV are at high risk as compared to white women. And women with first-degree relatives with CS cervix have a double risk of developing cervical cancer. Now, as unfortunately, the diagnosis of HPV is not that easy. The test is not so commonly available, neither it is done routinely. And in our setup in underdeveloped countries, it is really done in some of the laboratories. Regarding pathophysiology, 70% of all cervical cancers, they are squamous cell carcinoma, with adenocarcinoma comprises of 30% of the remaining tumors. So the most common type of cervical cancers are squamous cell in origin. Cervical glandular intraepithelial neoplasia is the precursor of adenocarcinoma of the cervix, and cervical glandular intraepithelial neoplasia occupies the endocervical canal, which is visualized on colposcopy. Now, what is colposcopy? Colposcopy is simply a microscope with a high magnifications, which can visualize the cervix in higher magnification. So, if any woman who has the PAP, there's a dyskiniosis or the PAP test shows some problems, so we always send the patient for the colposcopy so that we can pick up the early changes of intraepithelial neoplasia by colposcopy, and if required, biopsy can be done. So, cervical glandular intraepithelial neoplasia occupies the endocervical canal, which is visible on colposcopy, also or incidentally loop excision biopsies, which are carried out for high-grade CI. Now, CIN is cervical intraepithelial neoplasia. So, whenever you suspect any problem, any lesions, colposcopy is done in the woman. Colposcopy is not, facility is not available in everywhere. So in good setup or tertiary care center, it is present even in the outpatient department like we have in our ward, colposcopy. So, but still we are not doing it so routinely, but we definitely do it in those patients where we find that there is some lesion, so colposcopy is done. Cervical tumors are locally infiltrative, but they also spread via lymphatics and blood vessels. The local spreads, that means around the cervix, involves the parametrium, vagina, down road, bladder in front, and the rectum behind. So these are the lesions, these are the areas where the local spread of the cervix occurs, and distant metastases occur in pelvic and para-aortic lymph nodes, lung, and liver. Prognostic variables include, that means depending upon the tumor site, the stage, the nodal involvement, the lymphovascular space involvement, and histopathological subtype, we can say the prognosis of a patient. It also depends upon when the patient has presented first time in the OPD, early stage, later stage, with the growth or with the early changes. So this, all prognostic variables will tell us about the survival rate. Presence of positive pelvic lymph nodes reduces the survival rate by 50%. That means if spread has occurred to the pelvic lymph nodes, the survival rate is reduced, whereas involvement of para-aortic lymph nodes will reduce the survival by 75%. Regarding clinical presentation, the clinical presentation is variable. Sometimes the patient may present with microscopic or asymptomatic. They are only picked up incidentally following a blue biopsy of cervix for pre-invasive disease, or sometimes we find that the patient may present with abnormal bleeding, typically intermissive bleeding, post-coital bleeding, post-menopausal bleeding. So any woman who presents with abnormal bleeding should be investigated properly. Or sometimes they may present with obvious growth on the cervix, and these are friable, necrotic, and vascular masses of the growth on the cervix, which can at once be picked up by perspective examination or by manual examination, and they bleed a lot. A pelvic and speculum examination is always performed in a woman who present with abnormal vaginal bleeding or postpartum bleeding or postmenopausal bleeding, to see the state condition of the cervix, to see the vaginal walls as well. Sometimes if the growth is fungating or obvious growth is present or it's friable growth, the biopsy or the cervical biopsy can be taken easily in the outpatient department. But in few cases, the diagnosis can be missed as some tumors are endophytic and which is less clinically revealing. That means if it is inside the endocervical canal, so that not be visible on gross appearance. Investigations. Proper clinical staging of the disease is crucial for planning the treatment. So any cancers, they have this proper clinical staging. So staging, depending upon the staging of the disease, we always plan the treatment, whether surgery is required, radiotherapy is required, or chemotherapy is done. Initially, a patient who presents with abnormal bleeding or where we suspect the cervix, cervical cancer, the baseline investigation should be carried out, like complete blood count, random blood sugar, urea creatinine, liver function test, viral markers, and if she's not bleeding and you don't find any growth, but you find that the cervix is hard, Pap test also be taken. Pap test is taken from the age of 25 years till 65 years of age. Although this should be a routine practice, but still it has not been done in our setup routinely. FIGO staging is based on clinical examination and anesthesia with bimanual rectovaginal palpation should be done. That means not only you will do the vaginal examination, but also do the rectovaginal palpation to find out whether the cancer has spread locally to the rectum or to the perimeter, so that can also sometimes give you a good clue. Cervical biopsy is essential to confirm the malignancy and to assess the tumor type. So that means where you suspect on first speculum examination that the cervix is unhealthy or bleeds on touch, and the history is also going towards the cervical cancer. Usually these patients with cervical cancer, they have got multiple children as well. They are usually multiparous, very less likely to have nulliparous one. So you can have a biopsy under GA if it is not possible under anesthesia. That means you will do the examination anesthesia along with the portion where you suspect maybe a cancerous. So you can take the punch cervical biopsy. So it can be taken on multiple sites at the cervix. And then the histopathology will tell you the malignancy or the malignancy. And along with that, you can also examine the patient for any spread of the tumor or there is no spread. MRI of abdominal pelvis will assess the local spread of the disease in the cervix and pelvic lymph nodes. So where you think the cervical biopsy, where you're suspecting a woman having malignancy, you can have colposcopy or you can go for the cervical biopsy. And after the biopsy, you have to do the clinical staging, and MRI will also tell you the local spread of the disease, because you need to plan your surgery according or the treatment according to these two. X-ray chest is essential to exclude lung metastasis. IVP and cystoscopy are required to eliminate the renal and bladder involvement. But nowadays, intravenous myelogram is not done so commonly because by MRI we can also know about the condition of the kidney or the involvement of the ureter. Examination anesthesia can provide important information on the tumor, including the size of the disease, the fixity, whether it is fixed tumor, hard inconsistency, vaginal parameter, and rectal involvement. Small mobile tumors favors a surgical approach. Large, fixed, and vast tumors favor the use of radiotherapy. So in the initial stages, surgical approach may be possible, but in the later stages when the tumor has metastasized or fixed, it will not be possible to go for surgery. So this is the FIGO staging for cervical cancer. You can start from the stage 1. Stage 1 is again divided into A and B, which is again subdivided into A1 and A2, B1 and B2. So as a whole, if you think of stage 1, that is tumor confined to cervix. A1 is microscopic disease. That means it will not be visible on your gross appearance. Maximum horizontal dimension is 7 millimeters and depth of invasion is 5 millimeters. A2 is maximum horizontal dimension is 7 millimeter and depth of invasion between 3 to 5 mm. 1B, that was 1A, now it is 1B. Lesion confined to the cervix or preclinical lesion which is greater than 1A. 1B1, clinical lesion, that means it may be present, it may be obvious or clinically, no greater than 4 centimeter, and if it is more than 4 centimeter, then it will be included in 1B2. This is stage 1, tumor confined to cervix. So the survival rate in initial stage will be 83%. Stage 2 is tumor extends beyond the cervix, involves the vagina, but not the lower third, and the parametrium, but not the reach of the pelvic side wall. Again, it is subdivided. Stage 2A, tumor involves the vagina, that means the upper third, and 2B is tumor infiltrates the parametrium, that is around the cervix. Stage 3 involves the lower third of the vagina or extends to the pelvic side wall. A3A is tumor involves the lower third of vagina, and B, tumor extends to pelvic wall, or there may be hydronephrosis or non-functioning kidney due to ureteric obstruction caused by the tumor. So that means when the tumor goes beyond the cervix, involving the parametrium, the ureter is also nearby, so it will involve the ureter. That is why we have talked about the IVP, or we can even, with the MRI, this can be picked up, or cystoscopy to find the presence of growth in the bladder. Stage 4 is always the metastasis, involving the mucosa of the bladder, rectum, or extend beyond the true pelvis. Stage B is spread to the distant organ. Right, so this is the classification according to the International Federation of Gynae Ops PIGO staging system. So you can again see pictorial. See, 1A is confined to the cervix. 1A and 1B depending upon the lesion depth. Stage 1B, you can see lesion less than 4 centimeter. B2 is more than 4 centimeter. Stage 2 involves the upper vagina only, and B will involve the parametrium as well. And 3, you can see the lower vagina. B is again parametrium, maybe involving the ureter. And 4 is involving the bladder, the rectum, and distal metastasis. And the treatment of cancer always depends upon the staging of the disease, the future wishes of fertility, and the patient's health status. Now, regarding the cervical cancer, because this is a cancer which may appear in younger age group. So you might find few women who may want to preserve their fertility, want to preserve this uterus. So management of all cancer patients should be discussed with multidisciplinary team of the doctors. That means once you have diagnosed, once you have counseled the woman, they should have a proper discussion with the team of doctors, which will include the gynae oncologist, surgeon. Now we have subspecialty. If a woman has got advanced stage of cancer, she should be dealt with gynae oncologist surgeon. So they are not present in all setup, but now this is subspecialty, like we have in the gynae, the subspecialty of urogynecology, infertility, subfertility. The same way oncologist surgeon which has specialized in gynae, the pelvic cancers, they should be involved. The radiologist, the pathologist, they should all be involved. So that is why we say it is a teamwork. Anesthesia fitness is important preoperatively, as if you plan for radical surgery, may not be suitable in an unfit patient. The treatment of preclinical lesion, that is, if you remember, that is the stage 1A. These are microscopic tumor. must be removed with a clear margin of excision and coexisting CIN should be completely excised as the tumor is usually multifocal. So whenever you excise the tumor, you should always have the excision should be up to the clear margins. That means you should not miss tumor CIN, coexisting CIN, that is the cervical intraepithelial neoplasia, which should not be missed. If CIN is not completely excised, then repeat knife bone biopsy or lead should be carried out. We don't have leads or a large tube excision biopsy of transformation zone. We don't have in our setup here. But what we do, knife bone biopsy can be carried out, so that can be hemorrhage, may lead to hemorrhage as well. So in the early stage, these things can be carried out, because in those women who want to preserve their fertility and they do not want hysterectomy, this is the only thing which can be carried out. But a woman who has had family completed, so it should always be discussed with the team, with the family, about the treatment options. For stage 1A, local excision with good clear margin is all that is required. This will allow fertility to be preserved and hysterectomy is not warranted for those patients who want their fertility. The treatment of clinical invasive CS cervix, that is stage 1B. 1A was microscopic, right? Now 1B was tumor less than 4 centimeter or more than 4 centimeter to stage 4. Here the tumor volume is greater in patients with stage 1B. Therefore, fertility preserving treatment for this group is more challenging. It is very difficult to go for fertility preserving treatment or surgery in these patients. For stage 1B, radical hysterectomy and B1, I'm talking about B1 now. Radical hysterectomy and bilateral pelvic lymph node dissection is the standard of care, which is known as Rodheim's hysterectomy. That means not simple hysterectomy. Simple hysterectomy will include only the removal of the uterus, fallopian tubes, means uterus, cervix, and of course maybe the ovaries and tubes. But in radical hysterectomy or the Rodheim's hysterectomy, you have to dissect the parametrium as well, and the pelvic lymph node should also be removed along with the upper vagina. That means cervix, upper vagina of the upper one third of the vagina, uterus, and paracervical tissue. So these type of Rodheim hysterectomy are carried out by the gynecologist surgeon. So this is a specialized field. Pelvic lymph nodes removal include the obturator, internal and external iliac lymph nodes. The ovaries in perimenopausal women can be spared in few cases. For young women who want to conserve their fertility, radical trachelectomy. So that means surgical removal of the cervix and upper vagina is known as trachelectomy. And when you say radical, that means along with the bilateral pelvic lymph node dissection should be done. The radical surgery may result in complications like various dysfunction, sexual dysfunction due to vaginal shortening and lymphedema. Pelvic radiotherapy has similar success rate to surgery in stage 1B. This treatment can be considered in women who are morbidly obese for radical surgery or who are anesthetically unfit. So you can, if you are unable to carry out in a surgery, so this will all depend upon the type of patient, the BMI of the patient, whether she's fit, unfit, she's having other comorbids. This will all depend upon that, because radical surgery is considered to be a major surgery which may require hours, which may require many complications, which may result in complications. So it should be discussed with the patient, the success rate, and then if a patient is unfit or patient is morbidly obese or she's has other comorbids, then pelvic radiotherapy can also be started in stage 1B. When the disease is beyond the cervix, that means we talked about the stage 1A, we talked about the 1B, and now we are coming towards the stage 2. That means now it has gone beyond the cervix. Now, the radiotherapy with or without chemotherapy is the treatment of choice. Surgery may not be possible from stage 2 to stage 4. So, in the cervical cancer, only the initial staging, in the initial figo staging, the surgery can be done. But after the disease has spread beyond the cervix, it has gone either on the upper part of the vagina or to the perimetrium involvement has occurred, then radiotherapy with or without treatment becomes the treatment of choice. Surgery is associated with complications like severe hemorrhage, incomplete clearance of tumor in advanced cervical cancer. That is why it's better to go for radiotherapy. Incomplete excision of the tumor may also require adjuvant post-operative radiotherapy and may lead to high complication rate. Radiotherapy. Now, then we have to refer, once we confirm the tumor, the histopathology report, and we have done the figo storing and found that patient is not suitable for the surgical treatment, then the patient has to be sent to the radio oncology department. That is why in the beginning we said that this should be done with a multidisciplinary team. So you can discuss the patient with the gynae oncologist and the oncologist as well. So then they will start with the radiotherapy. Radiotherapy should be delivered to the tumor to eradicate the tumor with minimal damage to the surrounding tissue. So this is the aim of the radiotherapy. It is delivered in two ways: external beam radiotherapy, that is called tallotherapy, and number 2 is internal radiotherapy, which is called brachytherapy. Tallotherapy is given from a machine called linear accelerator, and radiation is delivered to the pelvis a distance from the patient. It is also, you can see this machine, linear accelerator machine in your book as well. So the patient is called according to her BMI, according to her tumor size. They set the dose of the radiotherapy, and the patient is called on the day for the radiotherapy, and then after a few hours, the patient is sent home. The dose of radiotherapy is carefully calculated and given in several fractions as an outpatient over 4 weeks. Brachytherapy is a radiotherapy technique where radiation is delivered internally to the patient. That means this has to be kept inside the uterus or the vagina. The selenium is used as a source of radiation, and selenium rods are inserted into the uterus under anesthesia. So this has to be done under anesthesia. And then these rods are then attached to the radiotherapy source. Brachytherapy provides a high dose of radiation to tumor with minimal side effect on the bladder and bowel, as its effects are targeted only 5 mm from the rod. Chemotherapy in the form of cisplatin can be given along with the radiotherapy, as this combination increases the cure rates more than when radiotherapy alone is given. The sites of radiotherapy include lethargy, bowel and bladder urgency, skin erythema, bowel perforation, vaginal stenosis, and premature ovarian failure. Palliative treatment is the treatment which is given in a woman where the surgery may not be possible. So when the surgery is not possible, we offer curative treatment. That means you just give to treat something to treat the symptoms, and tender loving care becomes important. So sometimes a woman with 70 or 80 years old who's even unable to walk, unable to handle herself, comes to us having cervical cancer stage 2 or 3. So I don't think so. We want her to have more problems with the life, as already she's having a lot of problems with not handling herself properly. So in those cases, we discussed with the family that if giving radiotherapy, chemotherapy might deteriorate her life more, or she may deteriorate, or she may have more problem if, rather than giving her tender loving care and offer her palliation of something for the palliation of symptoms. Like if she's having pain, we can give her some analgesics. If she is having bleeding, we can give her some bleeding. So this is known as palliative treatment in advanced stage disease when a woman is unfit for the surgery, who is unable her to go through the surgery or due to anesthesia fitness. Radiotherapy may be considered with a palliative intent in case of symptomatic bone metastasis as well. So let's talk about the cervical cancer in pregnancy. Even we have seen a patient who was very young, and she came in an OPD with pregnancy, and she was talking about the bleeding. So when she talked about the bleeding, the ultrasound was normal. So when we do pelvic examination, very gentle pelvic examination, we found that she has got some growth on the cervix. Even we were able to take the biopsy, the growth, we took a piece of the growth by manually in OPD, and we put it in saline, and then it was sent for histopathology and came out to be squamous cell cancer. So she was very young. She had one child and so second pregnancy. So of course we have to disclose her the problem, that what problem she's having to the family, but it is very difficult to declare these type of things in a younger patient, and she was already pregnant. Later on, we had advised her that she will be given treatment because she was already in advanced pregnancy. So of course, after the delivery or with the delivery, what should be done with her? So let's talk about the cervical cancer in the pregnancy. A woman present with abnormal vaginal bleeding during pregnancy, speculum examination is mandatory to rule out cervical cancer. Right, so gentle speculum examination should be done. Colposcopic appearance may be typical. The biopsy may be deferred as it may cause severe bleeding. So again, if you find there is something wrong on the cervix, colposcopy is also like a microscope. Very gently you can insert into the vagina and see the gross appearance of the cervix. But they say that you should defer the biopsy because it may lead to severe bleeding. That patient I talked about had already growth of the cervix, and she was bleeding from that growth. MRI can be done to access the strength of the disc. MRI is safe during pregnancy. It can be done without contrast. Treatment is seen as non-pregnant women. At less than 20 weeks, medical hysterectomy can be performed without prior induction of abortion. That means if you find the staging, according to the staging of the disease, if she's less than 20 weeks, you can discuss with the patient and radical hysterectomy can be carried out. For viable fetus, radical hysterectomy can be performed at the time of cesarean. That means if a woman is 30 weeks pregnant, 32 weeks pregnant, and she comes to have cancer, which needs to be treated by hysterectomy, so you can take out the baby at the time of cesarean section and perform the radical hysterectomy. So that will be the treatment of cervical cancer in the pregnancy. Follow up every 3 months for the first 2 years, every 6 months for the next 3 years, and yearly thereafter. Clinical examination to per spectrum and bimanual pelvic examination should be done, and pap tests should be done. Now, where the pap test, you can think of the pap test from the wall smear. The wall smear can be taken. In suspected recurrence, EU and biopsy and MRI should be done. Yes, they do come after radical hysterectomy, radiotherapy. After years and years, the patient may come with recurrence. You might find a growth of the vault of the vagina. You might find there's a bleeding from the vagina. Palliative chemotherapy is indicated of lesion and metastasis recurrence. Prevention. Now, the best thing about the cervical cancer is the screening test is available worldwide. And it is a very simple test. It's not very expensive. You just have to put speculum, and you have to take with you can take a smear with a special spatula, which is known as eye spatula. With the help of eye spatula, you just take the smear from the os that is around 360 degrees, and then you put it on the slide, fix it, and send it for pathology, that is dyskaryosis. That will show the dyskaryosis. So this will all be discussed, I think, in the pre-malignant conditions. When we talk about the pre-malignant condition of the cervix, then this will be discussed. So if a woman is having a regular pap test, so any type of dyskaryosis can be picked up and then it can be treated earlier. So prevention can reduce morbidity and mortality significantly and can be achieved by cervical screening for pre-invasive regions in high-risk population, use of barrier contraception to avoid having HPV and chlamydia infection, prevention of sexually transmitted disease, and improvement in socioeconomic status. So this is one of the tumor which has got the screening test available. Otherwise, the ovarian cancer has got no screening test available. Endometrial cancer hasn't got any screening test available, but where you find hyperplasia, you can go for sampling. But this is the only cervix of pelvic region which has got screening test by which the incidence of cervical cancer can be reduced in the population. So conclusion is prevention is better than cure, and pre-treatment evaluation proper staging is must, and it should be done in a setup, in a tertiary setup where all the facilities of gynae oncologist and the oncologist is available. So the references, this was taken by a gynae 10 teacher, gynae, 20th edition, and with the evidence-based ops gynecology edition. So I think this was all about the malignant disease of the cervix. And if you have any questions, so we can start with the questions as well. Saket, questions, David? Okay. Chat along. Questions?
साकिब चैट ऑन है।
अरे चैट कर सकते हैं?
हाँ हाँ, ये चैट में क्वेश्चन करेंगे, आंसर दे देंगे मैडम।
The anesthesia, you know, whenever you're going for the radical surgery means extensive surgery involving the uterus, tubes, and ovaries, maybe upper vagina, the parametrium, the dissection of lymph nodes. So that will be a major surgery, and it may take 2 hours. And along with that, the risk of having involvement or the complications of the bladder, the adjacent organs is important. So anesthesia practice is very important because these patients who present with malignancy, they usually have they are not in very good shape, or they are not in very good health. They may be having anemia, they may be having other comorbidities. So anesthesia fitness is always be taken from the anesthesia department for every patient. So even when you're going for a surgery, for a normal surgery of abdominal hysterectomy, vaginal hysterectomy, so anesthesia fitness is important. Until unless if the anesthetist says that she's not fit for the surgery, she's not fit for the 2 hours or 3 hours surgery, for this complicated surgery because of some comorbid, because of some problem. So it's very difficult to go for surgery. So we have to defer the surgery. Yes, radiotherapy is different. Chemotherapy is given in the form of injections, right? And radiotherapy is radiations. So they are different. EUA is examination, anesthesia, and FIBO. I discussed International Federation of Gynae Ops. So there are certain federations worldwide whose classification is considered to be the standard classification. So when you suspect a patient having some abnormality of the cervix, or when you suspect any growth of the cervix which is not visible, obviously, so you can go for examination under anesthesia and cervical biopsy. Any other questions? Do read from 10 teacher. It's given very nicely in 10 teacher. So I think next week we are going to have a lecture on the pre-malignant condition of the cervix and vagina. So from that, you will be able to go to the malignant conditions. So always, ideally, pre-malignant condition should be taught first and then the malignant. But I can't say anything about this. So next week, I think there's a lecture which will tell you what are the pre-malignant condition, how can you do the screening, what is the advantage of screening, what is the role of screening, what you will do if the patient comes with this history. So that is very important. So this condition is treated in the pre-malignant stage, so that will give you a better cure rather than going for the malignancy. Any other questions? No? साकिब अब तो कोई क्वेश्चन नहीं आया. Lecture, and inshallah we'll be meeting soon with another topic. And or whenever a topic is given to you, try to read it so you will learn more, you will have more questions to ask. Still, if you have any queries, you can ask us, no problem. Thank you very much, all of you.
Okay, madam, Allah Hafiz, take care.